Hello, my name is John Liu. I am a neurological surgeon at University of Southern California. I have been in practice for about 20 years. My specialty is in neurosurgery, spine surgery. And today what we're going to talk about is contemporary topics in spine surgery, including minimally invasive spine operations, laser operations, robotics, stem cells. There's just a lot of different topics that involve spine surgery. So hopefully we can try to review and talk about what works, what doesn't work. I don't have any disclosures for this lecture. Now, something to keep in mind, I always tell my patients, whenever I see patients, is that the body has a natural tendency to heal. So as a surgeon, we very rarely will go in and try to operate very quickly. There are certain times when there's some muscle weakness, but by and large, we really try to give the body a chance to heal itself. Now, again, we're going to talk a little bit about in terms of what are the kind of the hot topics today in spine surgery. We'll talk a little bit about stem cells. The big field in spine surgery and the big advancement, very popular, will be minimally invasive approaches, including endoscopic approaches. Then we'll talk a little bit about intraoperative navigation as well as some robotics. And these are some of the newer technologies that we have in spine surgery. So stem cells, you can think of what we have today in spine is, I think we all want to be able to have a stem cell injection and then have all our disc spaces that go back to being like 20 years younger. Unfortunately, that's not what we have today. And there are a lot of work being done, and hopefully years from now we will have that. What we do have today for stem cells is to assist in infusion, so that we can use stem cell products that can actually help us heal if we're in the process of doing some type of spine fusion operation. Now, the minimally invasive approach, a lot of times patients will ask, well, what exactly is minimally invasive? What does that mean? So you can think of the spine as surrounded by a lot of muscle. So the approach to the spine, when we have to expose the spine, sometimes can cause a lot of pain and can cause a long-term recovery. So the idea is to try to minimize that approach-related injury to the muscles. And so in the United States, what we've primarily been doing is using these tubular access, so what we call tubology, where we actually can use a tubular access to sequentially dilate through the muscle. So as opposed to stripping the muscles off the spine, we're going to actually work through the muscle fibers so we don't damage those muscle fibers. And we minimize the amount of injury that occurs with the muscles. So that creates a very small corridor and then we work through this small tubular approach. And that's essentially how we've been in the United States been looking at minimally invasive spine. This has been going on for about 20 years now. Now, minimally invasive is not new to just spine. There's been a lot of other spines, a lot of other surgery specialties. It really started off with cardiac thoracic. And Dr. Wickman, I think, really kind of have the best quote when he said minimal damage of biological tissue at the point of entrance of surgical instruments. And I think that's probably the best definition I've heard for minimally invasive spine. And again, a lot of cardiac operations today are done through these minimally invasive access. Gallbladder surgeries can be done as well as OBGYN and urology. So there's a lot of other surgical specialties also using minimally invasive approaches. In spine surgery, again, the problem with spine is they're really surrounded by a lot of muscles. So here's a good example in this picture where you have an incision in the back and you're stripping down these muscles with these big retractors and these Cobb elevators, and these are just instruments that we work. And you can see potentially what that can cause in terms of damage to the surrounding muscles. So for us to do our work in the spine, if we have to do this exposure, that can cause a lot of problems for the patient. So the idea is to try to minimize that approach injury. When I started my practice in 1998, this is how we did it. It's called basically endoscopic approach, where we actually use this minimally invasive muscle splitting, and then we put this small endoscope. And the technology at that point the endoscope just wasn't that good. The visualization was poor, and we just couldn't see things that well. So, but we kept the minimum invasive muscle dilation part, but instead of using endoscope, we actually used microscope, especially in the United States. That's what majority of the surgeons do today. There are different types of tubes, so you can think of it as fixed diameter tubes and modular tubes, where some of these tubes you can actually change the diameter, and depending on what operation you're going to do, we will use a different type of tube. But the whole idea is to try to keep these incisions as small as possible. Now, outside the United States, a lot of the minimally invasive development have been primarily through these endoscopic approach. And these are very popular outside the US, like in Europe and Asia. In the US, for some reason, we're not really quite sure, it never really caught on. But I think there are surgeons now that's rediscovering the endoscopic approach and actually becoming very interested in terms of learning these newer techniques that we can use the endoscope for. And again, in the US, the majority of what we do today is actually through a microscope as opposed to an endoscope. And there's a lot of advantages working through microscopes. You actually get a 3-dimension view as opposed to a two-dimension view. There's great lighting, and it's great for teaching. If you're teaching residents and fellows, you can actually both look through the microscope and see exactly what's going on. Even though in minimally invasive spine, we talk a lot about it and it's very popular, a lot of surgeons want to learn it, it's really less than 20% of all surgeries done. And that's pretty much across the board. And you can think, if you look at different countries, and that's really the pretty good number in that low 20 to 30% range. So the majority of patients that have spine surgery are done through a traditional open operation. Endoscope is even less, probably less than 1%. So the minimally invasive approaches have led us to kind of rediscover some older operations. And one operation that's been around for a long time is what's called foraminotomy. And basically what that is when you have a pinched nerve in your neck and you have a lot of pain going down the arms, and there's actually a disc or some type of bone spur hitting that nerve, one good operation to do is actually go from the back of your neck, and you can actually make a little tunnel in the back of the neck. And that was actually a very popular operation for a long time. The downside with that operation is that traditionally it's done through an open operation, and there's a lot of muscle splitting, and so it's actually a very painful operation. But with minimally invasive, we're actually able to rediscover and change that operation. So instead of doing an open operation with a lot of retractors, we just use a very small incision to allow patients to go home the same day, and with great outcome. So that's where I think, this is a good example. I'll kind of show you how we dilate through the muscles with these sequential tubes. And you look through the tube, and you can actually see the same anatomy that we would see if we were doing an open operation. And we can actually put drills in there. We can actually use special instruments to take away those bone spurs that's pushing on the nerve. And in this image, we'll actually show you the nerve. This little, this what's called a nerve hook is actually right underneath the nerve itself. So you can actually see that we can do a very good decompression of the nerve itself, and you can actually even pull out a small disc herniation and decompress that nerve even more. And as you take that tube out, you can actually see that muscle coming back together. And I think that's the beauty of this approach, is that we really haven't done any damage to the muscle. And as the muscle comes together, it goes back to its natural position. Now, I'm going to talk a little bit about how we use minimally invasive approaches for some of the lumbar operations too. And these are very popular, very common things that we see in terms of patients coming in to see us. That could include a disc herniation, lumbar stenosis, as well as some even tumor resection. So we'll kind of touch a little bit, I'll kind of just show you some examples in terms of what we can use minimally invasive techniques for. Here's an example of somebody, very common, 34-year-old with leg pains from a herniated disc. And this lends itself very nicely to a minimally invasive approach. The open operation is also a very good operation. So sometimes with very small operations like this, it may not necessarily make a big difference. But as you get some of these bigger operations that I'm going to show you, I think minimally invasive really kind of shows its advantage in terms of when we perform some of these bigger operations. Here's an example of what we call over-the-top bilateral decompression, where and the most common use for this is actually in folks with lumbar stenosis, where they have a lot of leg pains when they walk, and they basically can't walk, they sit and they lean forward. This is where a single incision, one-sided approach, where you get both sides decompressed through a very small incision. This is, again, an outpatient procedure. So the patient go home the same day. Here's an example. If you look at this CT scan, there's a osteophyte or a bone spur that's in the foramen. The foramen is where the nerve kind of comes out of the spine. And that pink arrow you can see is actually pointing at the bone spur. So if we were to do a traditional way to decompress that, you actually have to take that joint off. There's actually what's called a facet joint. You have to remove that joint to actually take that bone spur off. So if we take that joint off, then we probably have to fuse it at the same time because you're going to destabilize the spine. Now, instead of doing that, we can actually come from the other side through a minimally invasive approach and go basically sneak underneath the bone on the other side to reach that bone spur. The reason we come from the other side, you get a better angle. And through that angle, you can actually get that bone spur. And here you can see the post-op, where we actually, you can see the black, that's the air, the track that we took that allowed us to take that bone spur off without touching that facet joint. And this becomes really an outpatient procedure as opposed to a fusion operation where the patient needs to stay in the hospital for a few days. How about a tumor like this? And I actually just took care of a lady with a very similar tumor in the thoracic spine, where it was putting a lot of pressure on her spinal cord. Same fashion, we use the same approach, minimally invasive, unilateral approach, laminotomy, this kind of over-the-top decompression, allows us to open up the dura, which is the covering of the spine, the spinal cord, find this nerve, get it away from the nerve, find this tumor, get it away from the nerves, and then take that tumor out, again, through a very small incision. And we can actually close that covering, the dura, through the tubes with some special instrumentation. So all that can be done, and even fusions. Even somebody who needs a fusion, somebody needs a little bit bigger operation, we can actually use minimally invasive approach. And this is, you can actually see we actually use this navigation device. In USC, we actually have 3 of these what's called O-arm units that allows us to get some intraoperative CT scan, and so that allows us to tackle some of these more complicated operations and spinal deformities, minimally invasive approaches, so we can actually see the anatomy in real time. And this is us kind of putting in a spacer or a cage as part of the fusion operation, and you can actually put those screws in through the same tubular approach, or sometimes we can use this what's called screw extenders or percutaneous placement of the pedicle screws. And this is the incision that you typically get with a fusion like this. It's a very nice way to have a fusion operation if you ever need a fusion operation, versus, so you can actually have your choice, right? If you need a fusion, would you rather have the incision on the left, which is about the size of a quarter, or would you rather have the incision on the right? I think most of us will pick the minimally invasive incision. Now, there are a lot of data to show that minimally invasive compared to open fusion is just as effective, and very similar, but less blood loss and shorter hospital stays. Complication and fusion rates are very similar to open operation. So we compare very well to open operations, but we save the patient a lot of pain, less pain medication. And I think one of the more important components is that we also lower the risk of infection. This is a paper that I was one of the authors on when I was at Northwestern, where we actually had looked at 513 patients over a 10-year period. And the infection rates for minimally invasive fusion was 0.2%, 0.2%. Whereas an open fusion, same operation, done openly, is 4 to 10%. So you can see the dramatic change in terms of an infection. And you can almost, if you ever have an infection from a fusion operation, it can be quite complicated because sometimes you may have to go back in and take the hardware out, take the screws out. So I think this is a really a true advantage of a minimally invasive approach, we just hardly ever see deep infections anymore. How about these complicated operations like adult spinal deformity, tumors? And these are more complex, but it can also, we can also use minimally invasive techniques to help us tackle some of these more complicated operations. Using all variety of different techniques in the minimally invasive, we have really a kind of a 5 or 6 different techniques that we can use to help tackle these complicated operations. Here's a good example of a lady with a scoliosis, which is a abnormal curvature that she was causing her a lot of problems. And this is one where we actually was able to correct her scoliosis all through a percutaneous in a minimally invasive approach. Certainly cosmetically is much better, recovery is much better, lower infection risk, and you get the same result compared to an open operation. So we mentioned a little bit about navigation. Navigation, I think, is very important in minimally invasive spine because we're not exposing the entire spine. You have to know where things are. So when we use intra-op navigation, it really allows us to be very accurate, very precise, reduces the use of fluoroscopy, and I think it just makes things safer. The times that we actually have to take patients back to readjust at hardware or screw is very, very low compared to when we used to do these operations with a fluoroscopy or with what's called freehand techniques. So I think navigation certainly is a true advantage that we have in spine surgery today. It really kind of has changed how often we tackle some of these very complicated operations and tumors that destroys the normal anatomy, and to have navigation that really makes the operation much, much safer. Robotics is kind of the next generation of navigation, where you can actually have a robot with a moving arm, not only to precisely tell you where to go, but also it lines everything up so you know exactly where you need to go to place some of these hardware. So you can almost think of it as more of an advanced navigation. We've actually have used robots for some tumor resection, and this is actually done quite often with in urology right now, where they use a lot of robotics, and I think spine is starting to use the robots as well. And I think with that we can continue to push the envelope in terms of tackling some of these real complicated operations. So you can think of the intraoperative fluoroscopy, the old ways of putting in screws, is kind of like reading a map, right? So I'm old enough to remember we used to have a collection of maps in our glove compartment. So whenever we got to go somewhere, you kind of pull out the map and you have to find out what street you have to turn on. A navigation, it's almost like like if you turn on the GPS, right? So it tells you turn right here, turn left here, whereas a robotics is almost like the self-driving car, right? So you can think of it as each level of complexity gets you more in terms of potential assistance in tackling some of these more complicated spine operation. But we're also aware that you can't just rely on technology for everything. So you have to be careful. Even self-driving cars can have problems. So you can't rely on just on robotics, and so you still have to double check and make sure that the robot is actually doing what it's supposed to do. So with that, I do think minimally invasive is definitely here to stay. It's been around in my career, it's been around for at least 20 years. I started my practice in 1999, where we actually started doing minimally invasive at that point. So it really has come a long way. I think we still have a lot that we can get better at. And I think as new technology comes out, like different robots and other technologies, I think we're just going to get better and better with the minimally invasive techniques. And with that, I think with the improvement in minimally invasive, I think it just helps patient care overall in spine surgery. So with that, thank you so much for your attention, and I hope to see you soon.